Hello and welcome to this presentation on fluoropyrimidine treatment and DPYD testing. In this presentation I will discuss the fluoropyrimidine class of anti-cancer medications and associated toxicities. The dihydropyrimidine dehydrogenase or DPD enzyme will be covered and how deficiency of DPD is associated with reduced metabolism of fluoropyrimides and increased rates of toxicity. The rationale for testing of DPYD, the gene which codes for DPD, will be explained, and how the cancer pharmacists use these tests to personalise treatment. There are some limitations to DPYD testing, and a case study will be used to illustrate this. Fluoropyrimidines are a subtype of the antimetabolite chemotherapy drugs. Like other antimetabolite drugs, they preferentially target rapidly dividing cells and trick the cancer cell into incorporating an antimetabolite instead of the molecules it needs to create new genetic material. This prevents cancer cells from replicating. 5-fluorouracil, or 5-FU, is the fluoropyrimidine given IV and is a mainstay of treatment for a variety of cancer indications, including colorectal, breast, head and neck, pancreatic, and other gastrointestinal malignancies. Capecitabine and Tegafur are the oral prodrugs of 5-FU, that is, after they are taken orally, they are converted into 5-FU. As mentioned, all these drugs are antimetabolites and disrupt both DNA and RNA synthesis. 5-FU and its prodrugs are usually well tolerated, but can be associated with toxicity, and 10 to 40% of patients will develop grade 3 or greater adverse events. Life-threatening toxicity can occur with mortality rates of between 0.2 and 1%. With IV 5-FU, diarrhea and mucositis are the major dose-limiting side effects, and with oral capecitabine, hand-foot syndrome and diarrhea are the most common. At toxic therapeutic levels, RNA synthesis is the main mechanism leading to toxicity, and I will explain how this occurs. This diagram shows what is called the central dogma of genetics, that DNA is transcribed by messenger RNA and the transcript is used to generate the amino acid chain which leads to the protein product. The bases of DNA are A, C, G and T, while RNA has A, C, G and U. The RNA base U stands for uracil. 5-FU is essentially uracil with an added fluorine. Therefore, after intravenous administration of 5-FU, this medication can rapidly enter target cells using the same transport mechanism as uracil. The active metabolite which interrupts RNA synthesis is fluorouridine triphosphate, or FUTP, which is a 5-FU with a sugar phosphate group attached. This molecule closely corresponds to uridine triphosphate, or UTP, which is a uracil plus the sugar phosphate backbone, which is the molecule uracil forms within an RNA sequence. In simplified terms, 5-FU acts by competing for U in the RNA chain, which interrupts transcription and translation. We can see how at toxic levels this may cause issues in interfering with the function of healthy cells. Uridine triacetate, known by the brand name Vistagard, is a reversal agent which is given orally in 5-FU toxicity. This medication generates replacement of excess uracil molecules to compete with 5-FU and reverse toxicity. How is fluoropyrimidine toxicity caused? A lot of this is thought to be due to deficiency of the dihydropyrimidine dehydrogenase or DPD enzyme. This is an important enzyme used in the breakdown of the RNA-based uracil and the DNA-based thymine. Due to the similarity to uracil, DPD breaks down around 85% of 5-FU. Around 10% of 5-FU is excreted unchanged through the urine. Due to these processes, only a small percentage, 1 to 3% of 5-FU administered to a patient will act on cancer cells. Here we see how DPD deficiency reduces the amount of 5-FU that is inactivated, leading to a longer 5-FU half-life. If you follow the patient with reduced DPD activity on the right-hand side, they have a decreased amount of drug transformed to inactive metabolites by DPD, compared to patients with normal activity on the left-hand side. As a consequence, you can see that these patients have a larger amount of cytotoxic metabolites present, and these can reach toxic levels affecting healthy cells as well as cancer cells. In the population, a range of DPD deficiency is seen. This graph shows speed of metabolism of 5-FU on the x-axis and the level of DPD enzyme activity on the y-axis. As you move from left to right, you see that individuals with lowest DPD enzyme levels, or poor metabolizers, have a reduced speed of metabolism compared with normal metabolizers on the right, those with a standard level of DPD. So why do we test for DPYD? DPYD in italics denotes the DPD gene. We know there is a relationship between DPD deficiency and fluoropyrimidine toxicity. DPD deficiency is found in 3 to 6% of the population, and much of the evidence shows that there is a genetic basis for this. It has been shown that 70 to 90% of patients with a single DPYD variant experience grade 3 or more toxicity, while with testing, those figures reduce to around 25%. In the UK, we do about 38,000 tests per year in 4 variants of DPYD. We encounter both germline and somatic variants in relation to cancer diagnosis or risk. Somatic variants are the most common cause of cancer and are usually relating to environmental exposure causing mutated tumour cells. Clinically, we use information on somatic variants for targeted therapies, for example HER2-targeted therapy, trastuzumab. In cancer screening, we may also be interested in germline variants associated with increased risk, such as those found in the BRCA gene. In this context, DPYD testing is a pharmacogenetic test and as such uses germline variants to predict the pharmacology of the drug in an individual and either personalize the dose of fluoropyrimidine or select a more appropriate treatment. This diagram shows the 23 pairs of inherited chromosomes. DPYD is found in the first pair of chromosomes. As it is a pair inherited from the mother and father, it contains 2 DPYD gene copies known as alleles. This diagram shows how variants can lead to either a decreased or no function allele. When no variant is found, or the variant has no impact on the allele can be classed as having normal function. Having 2 normal alleles leads to a normal metabolizer status. Having a single decreased or no function allele, or 2 decreased function alleles, leads to an intermediate metabolizer status. 2 no function alleles, or 1 decreased and 1 no function allele, leads to a poor metabolizer status. In DPYD testing, alleles are assigned an activity score, and these activity scores are used to guide treatment. The normal function allele has an DPD activity score of 1. Decreased function alleles have scores of 0.5 and no function alleles have a score of 0. The scores from each allele are added together to provide a total DPD activity score. Patients with a score of 2 are normal metabolizers. Those with a score of 1.5 or 1 are intermediate metabolizers, while those with a score of 0.5 or 0 are poor metabolizers. Here are dose recommendations based on activity scores. Normal metabolizers have a score of 2 and can receive a standard dose of fluoropyrimidine. Those with an activity score of 1 or 1.5 are intermediate metabolizers and receive a 50% dose. Those with an activity score of 0 or 0.5 are poor metabolizers and fluoropyrimidines are not recommended. These are UK SAC guidelines, but also referred to local guidelines. This shows how in intermediate metabolizers, doses may be increased after cycle 1 up to 75% over subsequent cycles, and in those with an activity score of 1.5 up to a maximum of 85% over subsequent cycles. Some of the cancer pharmacist's roles and responsibilities are as follows. When screening fluoropyrimidine treatment, checking that a DPYD test is taken prior to cycle 1 of a fluoropyrimidine containing treatment. Based on the results of the DPYD test, advice on dose adjustments should be given if needed. When dose adjustments are made and patient has tolerated a lower dose on cycle 1, liaising with clinicians on whether a dose increase may be considered in subsequent cycles, liaising with testing lab in areas of uncertainty around testing and result interpretation, and potentially escalating to a clinician with specialist knowledge in complex cases. Finally, and importantly, counselling the patient of the meaning of the test and how it affects their treatment. How is DPYD test ordering done? It is a blood test and processed through the National Genomic Test Directory with a turnaround time of 5 days. There are local and international guidelines and also refer to local guidelines where available. This table shows the variants tested for in the test directory with activity scores ranging from 0 to 0.5. Please note the frequency of these alleles and that some are more prevalent in certain ancestries. As you can see, Europeans feature as prevalent ancestries for all the variants, as this test was set up based on data from predominantly European individuals. As the 4 variants tested for are based on European populations, and the UK is becoming more diverse, there is an urgent need to ensure that our testing is relevant and equitable to everybody. In order to make the test more useful for those not of European ancestry, new variants are being introduced to our testing methods. A new variant, seen at the top, has been added to the September 2024 UK SAT Board guidelines and is C557A to G. This is more prevalent in African ancestries. This variant is also being added to the National Genomic Test Directory. At the bottom, you can see some other well-known variants which we are not currently testing for. It is worth bearing in mind that if an individual has a variant not tested for, this will lead to an overestimation of DPD activity scores and an inappropriately high dose of fluoropyrimidine. This is a brief case study of an uncommon DPYD variant. A 46-year-old Caucasian male was diagnosed with left colon adenocarcinoma and had a left hemicolectomy before starting on Capox treatment consisting of oxaliplatin and the oral fluoropyrimidine capecitabine. At the time of treatment, DPYD testing was not widespread, and according to local guidelines, only a single DPYD variant was tested for. This variant was detected, leading to an intermediate metabolizer status and a 50% dose reduction. However, after a few days, he experienced life-threatening toxicities as shown. The patient was hospitalized and received intensive rehydration, prophylactic antimicrobials, GCSF, and blood transfusions. Further DPYD testing found an additional variant. As he had 2 variants and a total DPD activity score of 0.4, he was in fact a poor metabolizer and treatment should have been avoided. Fortunately, after 3 weeks of intensive therapy, the patient fully recovers. All other reported cases of patients with a poor metabolizer status at the time had resulted in death. This highlights the value of an accurate DPYD test and the need for improvement. As optional assignments, please see the attached documents. With this presentation, you will find attached the National UK SAT guidelines. Compare to your local guidelines and see how they compare. Review the DPYD genotyping recommendations from AMP attached. It lists many DPYD variants not found in UK SAT guidelines. Of those not already found on UK SAT guidelines, which would you add to make DPYD testing more accurate for your local population? If you scan the QR code, you will find instructions for a useful app that will help access DPYD and other pharmacogenetic guideline recommendations. You can input variants found in a patient test and see what guideline recommendations are available. To conclude, 5F units prodrugs are important and effective antimetabolite drugs used to treat cancer. DPD deficiency caused by DPYD variants leads to 5FU toxicity. Therefore, adjusting dosing after DPYD testing can help anticipate these issues. Current tests are unfortunately more beneficial to European populations, but this is something that has recently been addressed with the addition of the variants commonly seen in African ancestries and will hopefully continue to be addressed in the future. Pharmacists play a key role in ensuring DPYD tests are done during screening, advising on dose adjustments, and patient education and counselling. Increasingly, as pharmacogenetic tests become more widespread, pharmacists will be a common point of contact for queries relating to these tests.